So next scenario is infra renal abdominal aortic aneurysm. It's V8. A 73-year-old male smoker with COPD and hormonally controlled prostate cancer attends the clinic. He has 6 centimeter infrarenal abdominal aneurysm. What is your management plan? So 6 centimeter mean his annual risk of rupture is 10 to 20%. I will strongly counsel him regarding his smoking and to optimize his risk factor to cardiovascular system. And I will request blood test, ECG, chest X-ray, CT angiogram. I will request pulmonary function test, and if any respiratory problem, refer him to respiratory physician. Urology for prostate cancer to see the life expectancy and any evidence of METs. And then we will discuss the results at the vascular MDT. What are the risk factors for developing an AAA? So increasing age, smoking, family history, diabetes, and female genders reduce the risk, and its prevalence is 3 to 10%. What is the natural history of infrarenal aortic aneurysm? After rupture, AAA 50% do not reach the hospital, and of that reach hospital, 30% do not fit suitable for surgery. So 80% gone. If the operative mortality rate is around 50% for emergency open surgery, open aneurysm repair. According to UK small aneurysm trial, UK SAT reported that the rupture of risk increases at 5 centimeters. So 4 to 4.9 centimeter risk is 1.5% per annum, and 5 to 5.9 centimeter risk is 6.5% per year, and more than 8 risk is 40%. And a aneurysm expansion of more than 1 centimeter a year is also associated with a higher risk of rupture, and women have a higher rupture risk than men for a given aortic size. The threshold for elective surgical treatment is 5.5 centimeter in men and 5 centimeter in women. In Caucasian population, Asians generally tend to have smaller anatomy, and so it is not wrong to offer surgery when the aneurysm reaches 5 centimeter in men and 4.5 centimeter in women. What is the operative risk for open repair versus endovascular repair? So it's 5.6% mortality, and for EVAR it's 1.6%. Open is 5.6 and EVAR is 1.6%. What randomized controlled trials data are available in assessing the role of endovascular repair? Infrarenal abdominal aneurysm. So EVAR 1 trial, which is a Dutch randomized trial, and now EVAR 2 trial is as well. So a 75-year-old gentleman presented with 5 centimeter non-tender aortic aneurysm during routine ultrasound scan for investigation of immature and possibly renal stones. How would you manage this aneurysm? So this aneurysm didn't reach the threshold for intervention, so we will book him for surveillance ultrasound scan in 3 months' time. 6 months later, the aneurysm becomes 5.7 centimeter in maximal diameter on ultrasound scan. What would you do? Now this patient reaches the threshold for intervention, which is 5.5 centimeter. This needs surgery. What else may you need to plan surgery? So we will need patient cardiovascular workup, respiratory workup, renal function test, and then we can further assess, stratify his risk. So for cardio workup, he needs either MIPI scan or dobutamine echo. If non-ischemic heart disease, then his cardiac full workup and cardiac opinion will be needed. For respiratory, he will need lung function test, and FEV1 is the predictor for mortality in the aortic surgery. CT scan comes back with a juxtarenal aortic aneurysm with normal iliac bifurcation. Aneurysm is 5.7 centimeter. The common iliac arteries both are 3 centimeter in length with a diameter of 0.9 centimeter, and external iliac artery are both patent with diameter of 0.8 centimeter. There is no occlusive disease in the internal iliac or common femoral arteries. Would you offer endovascular or open repair to this patient? What are the current guidelines? So clearly the aortic aneurysm has no neck. There is no conventional off-shelf device which can be used for the aortic stenting. He needs a customized fenestrated device, which is only recommended for trial studies. But if patient has good cardiovascular system, patient can have open aortic aneurysm repair. Current UK NICE guidelines suggest that all aneurysm should be done open if patient is fit. You were asked to consent the patient for open aortic aneurysm. What are the major complication and risk you must mention? Risk of aortic aneurysm is minimal, 5% mortality, and morbidity includes the MI, cardiac failure, renal function, post-op pneumonia, gut ischemia 2%, limb ischemia, CVA, and multiple organ failure. The patient decided against open aortic surgery and went home to think about alternative treatment. However, 3 weeks later, he was admitted to A&E with abdominal pain and hypertension with a systolic of 90/60 and GCS of 15. How would you manage him? Looks like he has a contained rupture. Patient needs resuscitation and then surgery, and should have CTA if stable to plan EVAR. If non-stable, patient need to go to operating room. He needs dripping and pending before putting in sleep. What approach would you choose for patient? Which is better? What is the evidence? So it depends on the local expertise, stability of the patient, and also some centers may not have graft ready to start. The setting up of the hybrid unit for EVAR will take an hour with the radiographer, so if patient is very unstable, open surgery should be appropriate. With the improved study, there is no difference in the mortality between open and EVAR. However, EVAR in the rupture scenario survive better in long-term follow-up after 6 years. Thank you.